Okay, so we can start now, as the majority of the people here are logged in. I would like to introduce one of our lecturer for the day. Today we have Dr. Yahya Al-Azri from Sultanate Oman. He is a hepatobiliary surgeon in Sultanate Oman, and he is a consultant hepatobiliary and transplant surgeon. He is head of the hepatobiliary department at Sultanate Oman, and he is an Arab board representative for the Ministry of Health. Welcome, Dr. Yahya.
Thank you.
Hello. And today we're going to have the lecture on liver lesions.
Great.
So we can start.
Good evening, everybody. I'm delighted to talk to you today about the liver lesions. Liver lesions is a big topic by itself, and I will try my best in the coming 90 minutes assigned to take you around in this journey and to help you to try to understand some of the basically the concepts of managing these lesions.
I think you need to maximize the slide and then click next on the keyboard.
These are the objectives assigned for the topic, and I'm going to try my best to achieve these objectives. To start with, first, the liver is a very important organ, as you all know, and there are different pathologies can affect the liver, from neoplasms, abscesses, cysts, and chronic liver diseases which end up with portal hypertension. If we talk about the neoplasms, we classify them, or we divide them into benign and malignant. The benign neoplasms will include hemangiomas, focal nodular hyperplasia, and adenomas, bile duct hamartomas. While the malignant, the most common, of course, is the liver metastasis and hepatocellular carcinoma, and add to that intrahepatic cholangiomas. Abscesses, biogenic, amoebic, and fungal. And for the cysts, we divide them into parasitic and non-parasitic. The parasitic, we most of the time talk about Echinococcus hydatid cyst, and the non-parasitic are also divided into simple or polycystic biliary cyst adenoma and biliary cyst adenocarcinoma. For portal hypertension, the liver lesions which end up coming is the nodular hyperplasia, and eventually this evolve into HCC. This is Oman, the Green Mountain in Oman. As I said, the topic is long. I'll try to entertain you in between. One of the biggest mountain in Oman. It's the temperature now is around 25, 26, compared to Muscat, which is about 35. Liver cysts. So, liver cysts, as I said, the non-parasitic cysts are divided into benign and neoplastic. And the benign lesions will include the simple liver cysts and polycystic liver disease. The neoplastic ones are mostly the biliary cyst adenoma, which might evolve into a biliary cyst adenocarcinoma. This can be solitary or multiple. Usually they are incidental, and usually they are asymptomatic. The main point to distinguish between the benign and neoplastic lesions, cystic lesions in the liver, is the presence of a mass or a septa within the cyst. For the benign lesions, the treatment is most of the time is conservative, for asymptomatic simple cysts. And for those lesions which are symptomatic, you might consider laparoscopic fenestration. Some patients with polycystic liver disease, which usually does not affect the liver function, might end up getting transplanted if the liver becomes huge and associated with other organ failure like kidney or pancreas. Regarding neoplastic lesions, the biliary cyst adenoma is a pre-malignant condition. And as I said, it can evolve into a biliary cyst adenocarcinoma. The treatment for cyst adenoma is inoculation, while for cyst adenocarcinoma, resection. This is a schematic diagram for a CT scan. The one in the left side, top left side, is a simple liver cyst. The way it's a hypodense lesion, you can see the wall, thin, no projections, no mass within the cyst itself. Right-hand side, you can see the liver with so many cysts. This is a polycystic liver. And lower down here, you can see this is the biliary cyst adenocarcinoma, which is proved actually. You can see the cyst with septa present, and there is also a mass here. So this was resected, and it turned out to be a biliary cyst adenocarcinoma. So that the first 2-3 slides were about the non-parasitic cysts. And now I'm going to move into the parasitic cysts, which is the hydatid cyst. The hydatid cyst is the most common in Mediterranean region, Middle East, and South America. It is caused by infection with Echinococcus species. And dogs, mostly the primary host for this intestinal tapeworm. There are 4 species can infect human beings. And the most common, of course, is Echinococcus granulosus and Echinococcus multilocularius. This is how the adult Echinococcus looks like. And this is the how does the liver hydatid cyst look like? The first is the germinal layer, and B is the daughter cyst, which is this one. And you have the cirrhosis, which is inside the daughter cyst, and you have the cavity of the primary cyst. And this is the laminated layer, and this is the host response layer when the infection develops in the liver and the reaction from the liver parenchyma takes place. How to diagnose parasitic liver cysts? The 2 important things to keep in mind is the Echinococcus serology, and also we have to look at the blood film for eosinophilia and the radiology. Percutaneous aspiration of the cyst and biopsy should be avoided because you can spill the cirrhosis into the abdominal cavity and you cause an anaphylactic shock. And usually a combination of imaging and serology can give you the diagnosis. In terms of treatment for hydatid cysts, medical therapy, the most common used antihelminth is albendazole. This is represented in the medical therapy, which you should give for at least 2 weeks before any intervention. The less invasive procedure, which is the percutaneous aspiration and introduction of protocerrosis agent and reaspiration, which is called PAIR. This is done by the radiologist, usually, interventional radiologist. They inject a hypertonic saline, 10 to 20%, or they might inject 80% alcohol. But if there was a biliary communication confirmed between the cyst, the hydatid cyst, and the bile duct, alcohol, of course, should be avoided because it can cause severe cholangitis and damage to the ducts. The third option for treating this condition is surgery, of course. We can do the watch and wait in some patients with inactive or degenerative cysts, which usually are calcified. you might observe this without doing an intervention because this has been tackled by the body and the immune system itself in few patients. This is a CT scan of a patient whom I have operated on. You can see the cyst and the germinal layer. It is filled with fluid. CT scan and MRI can help you to delineate if there is any infection, active infection happening in the cyst. If there is, the MRI can help you if there is any biliary communication in some situations. You can also detect gas, which suggests infection on top of bacterial, on top of Echinococcus infection sometimes. And also some calcification within the cyst can be seen in these scans. The CT scan and MRI helps you to anatomically roadmap the liver if you are going to intervene. And also it helps you to detect complications. So this is basically the CT scan, which show you the cyst in segment 6 and 5. This patient was also having hydatid cyst also in the lungs. So there was 2 lesions, one in the right loop and one in the left loop here. What I have done for this case is laparoscopic intervention. As you can see, this is the same patient which I have showed you the CT scan. This is the whole cyst, hydatid cyst. You can see the gauze here, which was impregnated with the hypertonic saline and put at the subhepatic area. Then I have punctured the cyst, aspirated immediately with a strong suction, whatever content inside, and then usually, if you have a germinal layer, as you have seen in the CT scan, it looks like inside, it is like a towel. It's a white towel, which is folded inside the cyst itself. So after we do the aspiration and suction, aggressive suctioning, again, I install the hypertonic saline a couple of times to sterilize as much as possible the cavity. And then I open the cavity along the liver, close to the liver edge, and I remove the whole sac, the whole cyst wall, sorry. And after that, of course, I removed with that the germinal layer, which was, in this case, it was really big, actually, inside. And then this patient also had lung resection, segmental lung resection, and actually he did very well without recurrence so far. Unfortunately, I don't have the full video. I tried to download the video, but it's very difficult. I tried it. There's some technical issue with that. Anyway, I have explained what I have done. And this is what we have done sometimes in some open procedures for the hydatid cyst. We go and open these cysts, and we do a pericystectomy. We remove the whole cyst. This is a pericystectomy, how it is done. As you can see in the description, basically you go into the plane between the host pericyst and the liver tissue, and you take the whole cyst completely in one go. Again, this is Oman, where I come from, and basically I'm showing you the biggest, the highest mountain in the Middle East, which is in Oman. This is Jebel Shams, and we have the Grand Canyon, which is of course less or smaller, a little bit smaller than the one in Arizona, US. Next, I'll take you to, please.
Sorry to interrupt. Just a random question: is Jebel Shams in Salalah or Muscat?
It is not in Muscat. It is in Dakhliya, the Dakhliya region, actually. This is Dakhliya region. It's not in Muscat. You should make it visit one day, but after Corona, please. It's very nice, very big mountain, and it takes you at least 1 hour to reach the top of the mountain. It's very beautiful.
Definitely.
My suggestion, please keep. If you have any question, just have it in an A4, and at the end of the presentation, I can go through all the questions which you have. Next, I'm going to talk about liver metastasis. Liver metastasis is the most common malignancy of the liver. The common site for metastasis from a GI tract is, of course, the liver. The metastasis to the liver can be from a colorectal cancer, a neuroendocrine tumor, melanoma, breast, and stomach. These are the most common, actually, which we see in a clinical practice. For colorectal metastasis, 50% of colorectal cancer will develop metastasis. And if you don't treat this hepatic metastasis, the prognosis will be poor. Survival is 6 to 12 months. Resection is associated with 25 to 35% 5-year survival. And operation should be offered for all resectable colorectal metastasis. In terms of evaluation or preoperative evaluation for this patient, colonoscopy should be done in the last 6 months to document the absence of anastomotic recurrence or metachronous lesions. You should have a CT scan to identify all intrahepatic and extrahepatic metastasis. MRI liver for METs is, if potentially resectable, I do it in almost most of the cases, and the reason for that because there are small. Sometimes we pick up small lesions less than 1 centimeter, which were not picked up by the Triphasic Ct liver CT scan. PET CT is not routinely done from our side, but usually we found the medical oncologist has already asked for it. It helps to monitor recurrence, to look for sometimes occult lesions like in lymph nodes or even the anastomotic, colonic anastomotic area. This is a CT scan basically showing liver mets from colorectal cancer. Overall, in colorectal cancer, the lesions in the liver are hypovascular and they are hypoattenuating. But in patients who have, for example, a neuroendocrine tumor, whether it is coming from the appendix, from the bowel, from the pancreas, if they metastasize to the liver, they're usually enhancing lesions. So this is, the radiologist will be able to tell you the possibility whether this is a colorectal or a neuroendocrine. Of course, not in all cases, but they might sometimes give you some hints to work up the patient further when the patient presents with an unknown etiology or primary. For colorectal cancer and liver metastasis patients, please remember there is no individual management by a particular team for these patients. It has to be run through an MDT meeting. And the champions in these meetings are the medical oncologist, the surgeons, and the interventional radiologist, and also, of course, the gastroenterologist. For the chemotherapy, it depends in the center, okay? It depends also on the patient. It depends on the pathology of the disease sometimes, whether to go for an adjuvant or a new adjuvant chemotherapy. You should be aware of, I'm sure at whatever center you are going to practice, you are going to find a medical oncologist who basically follow certain protocol, for example, NCCN guidelines or any other European or Canadian or US protocols for managing these cases. So whichever is the protocol, eventually the chemotherapies are almost more or less the same. But some people would prefer to give before surgery, some people would give after surgery. That also depends, as I said, on the presentation, on the clinical condition of the patient. Surgery, what we do for these patients, either we do metastastectomy, or we do partial hepatectomy, or we do a primary colonic tumor resection and the secondary liver resection, either simultaneous or sequential. See, these are the options, the surgical options from our side we offer for these patients. Our colleagues, the radiologists, they come in the picture most of the time if the patient is not operable. So they can do local ablation with RFA. Also, they can do transarterial chemotherapy, embolization. But survival after this is low. So people still, taste is out of the out of the picture in the management of colorectal cancer. Most of the time, if the patient requires chemotherapy, it will be given systematic rather than directly in the hepatic artery. Going back to surgery, combination of basically combination of surgery for the liver and the colon avoids the second laparotomy and reduces the overall complications. However, if we are going to do an extended hepatectomy or a low anterior section, staged approach is preferable because of the complications that can happen from both sides. And predictive poor prognostic factors after section of hepatic colorectal metastasis include nodes which are positive in the primary tumor, if there are multiple metastases in the liver, if the size of the largest metastasis is more than 5 centimeters. So these are poor prognostic findings in a patient who is going to go for a hepatic colorectal metastasis resection. Unresectable hepatic colorectal metastasis, as I said, we treat them sometimes with local ablation. I frequently don't recommend this, but that depends on the MDT meeting and how bad is the patient. I showed you these two slides basically to make you aware that about the NCCN guidelines. If you look here, this is for resectable synchronous liver and or lung metastasis. Patients who have a lung metastasis are not a contraindication for liver resection because we have seen that from different studies has been done. If you do lung resection combined with the liver, the survival, there is improvement in the survival. So we are aggressive now with these patients. Lung metastasis, we resect. Liver metastasis, we resect. And of course, that will be also covered or supplemented with chemotherapy, whether a neoadjuvant or adjuvant chemotherapy. This is for unresectable synchronous liver and or lung metastasis. For unresectable metastasis in the liver, sometimes after giving neoadjuvant chemotherapy, basically these patients they do deletions. They show some good response. So basically, we go ahead after that in many cases and do the resection. So you have to reassess, reevaluate the patient after you give chemotherapy for the liver metastasis in those patients who are labeled initially unresectable. And for postoperative follow-up, the serial physical examination is the one of the important things that you should do for these patients when they come to the clinic. Serum CA level, and the most important thing, serum CA level, of course, will be very important if you have initial CA was high, but if it was not high at the beginning, it won't really help. But for a CT chest, abdomen, and pelvis, it should be done every 3 to 6 months for the first 2 years, and then every 6 to 12 months for subsequent 3 years. So a total of 5 years, you should follow up this patient with CT scan. The idea is basically to pick up metastasis and pick up recurrence and to intervene early before late. And as I mentioned initially, PET CT scan to assess response on liver recurrence after imaging guided liver directed therapy. But it is not a routine thing done. This is another, I'm going to show you many things about Oman. Unfortunately, I think you should come to Oman, but please don't come now. As I said, you should come after Corona. This is a Bima sinkhole. We believe that a big star or one of the biggest stars has fallen and created this. And it is basically this is sinkhole is filled with water. And one of the things, the miracle that we have here in Oman. I think you should take a deep breath, and maybe we can go further to talk about liver abscesses. So, as I mentioned in the initial slide, we look at liver abscesses, whether they are pyogenic, amoebic, or fungal-related. Pyogenic abscesses, as a surgeon, you will be called for these sometimes for these lesions in the liver to help whether there is anything surgical you can offer. So pyogenic abscesses, whether the single bug or a mixed, most common organisms, of course, is Klebsiella pneumonia, E. coli, and staph, amoebic Entamoeba histolytica, and usually these patients will have a recent history of travel to an endemic area. Fungal abscesses are more common in immune-compromised patients, whether patients on chemotherapy, patients with HIV, or for example, acid chemotherapy like myeloid leukemias or lymphomas or any other cancers. The pathogenesis of liver abscesses, most of the time it is hematogenesis, or directly through the peritoneal seeding, through the channels, lymphatics. We see sometimes liver abscesses after rupture appendicitis and diverticulitis, perforated, or also colorectal cancers when there is bacteremia. Go through the portal vein to the liver. Sometimes you might see a liver abscess directly from the gallbladder or lymphedema or perforated in the liver, or sometimes from cholangitis. You might see multiple small liver abscesses in the liver parenchyma around the hilum. Liver abscesses are more common in the right side. This is a diagram basically showing that different cancer in the colon and the percentage of these tumors that might cause liver abscesses. For example, you see in the transverse 7.6%, the ascending is 18%. Of course, most common from the sigmoid, 40% of the sigmoid cancers might cause metastatic liver abscesses. And these abscesses are more on the right side. How do these patients present? They present with abdominal pain, fever, weight loss, anorexia. They might present with fatigue. And in terms of investigation, the white cell count usually is high, CRP is high. If you do a chest X-ray at the beginning in ER, when they come, you might see the right diaphragm elevated or right pleural effusion. Ultrasound, the abdomen is very good actually to diagnose these patients, and it should be the first line. You can it's an operator dependent, but if it is done by a reasonably experienced radiologist, he will be able to tell you and diagnose a liver abscess. We use CT abdomen if we're looking for multiple abscesses and if they are causing some problems like complications, perforation, rupture, or they are pressing on the ducts or the vessels, or other associated complication. You might ask for a CT abdomen. The treatment for liver abscesses, please remember the key point is that systemic antibiotic has to be started ASAP. And of course, percutaneous drainage, which is done usually by the radiologist, IR, or surgical. We offer sometimes surgical drainage. When we usually offer that, we offer surgical drainage if the abscess is multiloculated and it has failed at least one or twice a percutaneous drainage. Then we'll come in the picture and we offer the surgical laparoscopic drainage of these abscesses. This is not Europe. This is Salalah. Actually, the temperature nowadays in Salalah is around 25, while in Muscat it is around 35 to 40. And the temperature further going to drop in Salalah in the coming few weeks, and it will reach up to between 18 to 20. I'm going to move now to talk about the benign hepatic neoplasms. And the most important ones are the hemangioma, the FNH, the liver adenoma, and the bile duct hamartoma. In general, benign solid lesions of the liver tissue has originate from two tissues, the epithelial and the mesenchymal. And the epithelial gives you the hepatocellular tissue and gives you the cholangiocellular, which basically end up giving you the bile ducts, and the hepatocellular gives you the hepatocyte. On the other side, the mesenchymal tissue gives you the blood vessels, the adipose tissue, and gives you the muscles, the muscles in the vessels. Here, if you look at the epithelial origin, the hepatocellular can give you the FNH and adenoma. So basically, that is the origin of the focal nodular hyperplasia and adenoma. It's a hepatocellular in origin. While bile duct adenomas, these are cholangiocellular also from epithelial. Hemangioma, they arise from the blood vessels, from a mesenchymal origin, and the angiolipomas, they arise from the adipose tissue, and leiomyomas also from the mesenchymal origin. You have the hamartomas, which is basically mixed epithelial and mesenchymal between the two. Okay, the hamartomas. For all these benign lesions, I'm going to basically give you introduction, talk about a little bit of symptomatology, the histopathology of each one, how to diagnose them, what are the radiological findings, and how to manage this. We'll start with hemangiomas. These are the most common benign solid liver lesions, account for about 3 to 20%. You will notice, unfortunately, all these benign lesions are more common in females. Okay, so usually more common in middle-aged women, and the female-to-male ratio is 5:1. The size of the hemangioma can be between 5 to 20 centimeters. Usually the blood supply is divided on the hepatic artery. And some of these tumors express estrogen receptors, and accelerated growth has been associated with high estrogen status, it's like in pregnancy and some OCP, patients who are taking OCPs. Malignant degeneration does not occur in hemangiomas. That is straight and clear. In terms of histopathology, this is a picture of macroscopic picture. Basically, you can see the hemangioma in the liver. This is spherical. It is well circumscribed. This is also another one here. You can see here. They are usually soft in the operating room they are usually soft when we press on them. And they are easily compressible. And this is after resection, one hemangioma. You can see how it looks like. This is microscopically. You can see cluster of blood-filled cavities. These are the blood-filled cavities with multiple large vascular channels. These are all channels, long ones, and a single layer of endothelial cell supported by collagen. This is collagen supporting this. Okay, so this is one endothelial single endothelial layer. The clinical presentation of hemangioma, usually it is incidental and asymptomatic. These are the most common presentation. However, some patients might present with non-specific abdominal pain, and they go, for example, for epigastric pain, and then incidentally they have an ultrasound, and then they pick up a lesion in the liver and turn out to be a hemangioma. Intermittent symptoms may occur if necrosis or infarction or thrombosis happen within the hemangioma from sequestration of platelets and clotting factors. That can happen in giant hemangiomas. Okay, some of the large hemangiomas, you can have sequestration of platelets, so they will develop thrombocytopenia, sequestration of coagulation factor, and they will be coagulopathic. And this is a syndrome called Kazabach-Merritt syndrome. I have seen one case, and unfortunately, these patients have to be aggressive with them and they can be very sick sometimes, and you might need to go surgically and resect that large hemangioma. Large threatening hemorrhage is extremely rare, but it can happen, especially in pedunculated hemangiomas, due to trauma, or sometimes because of the weight of the hemangioma is not supported, not like the one in the liver, because of the weight, and then it ruptured. In terms of diagnosis, laboratory abnormalities are rare in these cases. Yeah, and most of the patients will have everything normal. Diagnosis is done by imaging. you don't need to biopsy hemangioma. You will run into bleeding, which is sometimes difficult to control. In ultrasound, you might see a well-defined, lobulated, homogeneous, and hyperechoic mass. If you see a hypoechoic region in the mass, that might represent hemorrhage or calcification in the hemangioma or fibrosis. The ultrasonographer sometimes, when he sees these lesions are compressible, that is pathognomonic sometimes for hemangioma. This is a triphasic CT scan. You can see the periphery of the lesion. Okay, there is peripheral nodular enhancement, and this nodular enhancement moves toward the center with centripetal flow. And what happened in the delayed phase, there is a delayed washout. Okay, so there will be delayed washout in the venous phase. So peripheral enhancement with centripetal flow, with delayed washout in the venous portovenous phase. That is what you will see in the CT scan. This is an MRI, basically a T1 weight image of the liver after a contrast infusion. It is demonstrating the hyper intense peripheral enhancement. As you can see, it's in a globular pattern, and it is classical of hemangioma. Technetium-99 labeled RBC. Sometimes you might need to do it in some of these lesions which are not typical or diagnosed by CT scan or an MR, but it is rare. And you can see here the pooling of blood in the hemangioma, okay, with time. So technetium labeled RBC scan can be used in these cases. If you still have diagnostic uncertainty, then you move to the an invasive procedure, which is hepatic arteriography. So basically, you demonstrate here, if you can see this image on this left side, you can see the common hepatic artery. And you can see the lesion here, which is getting enhancing after injecting of the contrast in arterial, of course, arterial phase. This is after, just before the after injection of the contrast. You can see still the contrast is retained in the lesion. So this is, we don't nowadays, extremely rare to go for such a procedure. Neither RBC scan. Okay, most of the time we are able to diagnose these lesions by CT scan or even an MRI. How to manage hemangiomas? Of course, as I said, the indication for intervention, symptomatic, or patient have complication like rupture or sequestration of platelets and coagulation factors, or inability to exclude malignancy, which is again very rare with the current images. In terms of management, most of the hemangiomas are treated by observation. Sometimes, if you need to go surgically, you can inoculate them because these are benign lesions. Formal anatomical resection like right hepatectomy only used for big tumors. Some rare cases where the patient for temporary help, for example, your patient is not well, you might do embolization. And also radiation, with the low dose of radiation is used. But most of the time, as I said, small lesions can be observed. You don't need to worry about them. You can inoculate those symptomatic ones, and you can formally resect. But embolization and radiation for those patients who are not fit for surgery, or you need something, patient is sick and you want to do something temporary to try to control the bleeding, for example. These are the other two options available for treating hemangiomas. I'm going to move now to focal nodular hyperplasia. It's the second most common benign hepatic neoplasm. Again, it is more common in females, childbearing age, and 6 to 8 to 1, which is the ratio of females to male. The association with oral contraceptives has been suggested, but correlation is much lower than seen with hepatic adenomas. And again, very important, malignant transformation has not been reported. Histopathologically, if you look at this, this is gross. This is an FNH. If you look at carefully at the middle, you can see a central scar. You can see the scar here. You can see here. This is a lobule, another lobule here. So microscopically well circumscribed, lobulated, but unencapsulated. There is no capsule. You might report, the histopathology might report a pseudocapsule because of the reaction of the liver parenchyma, but there is no true capsule. Microscopically, again, you can see the nodularity. You can see the scar tissue in between. This is, the parenchyma, again, with the hepatocytes, sinusoids, and Kupffer cells. So, and this is the fibrous tissue in between. Clinical presentation, asymptomatic, the majority of cases. Some patients might present with right upper quadrant pain with a palpable mass if it is large. Spontaneous rupture with hemorrhage is very, very rare in FNH. It is critical to distinguish between FNH and fibrolamellar HCC. Both can have central scar caused by the fibrous band in the center. So whenever you have an FNH, you have to make sure that this is not a fibrolamellar HCC. And I'm going to talk separately about fibrolamellar HCC later. Diagnosis, of course, like any other lesion, you start with ultrasound. However, it does not discriminate FNH from other lesion. And the reason for this, because the echogenicity is very similar to that of surrounding lumbar liver. If you remember, I told you the FNH is basically from a hepatocellular tissue, epithelial. This is a CT scan of a patient with focal nodular hyperplasia. If you see this triphasic CT scan, this is an arterial face. You can see the homogeneous enhancement, and you can see the central scar here. Okay, this is a little bit delayed. There is rapid washout with minimal enhancement in the delayed venous. You can see maybe a little bit difficult to approach, but these are characterized by radiating septa. Which, if you imagine the wheel of a bicycle, with the middle is the central scar and the spokes, which is going to different areas to support the tire. This is what is the typical presentation of in the CT scan of a patient with the FNH. This is another image for FNH, and you can see here a branch from the hepatic artery supplying the this lesion and enhancing. This is an MRI picture for an FNH. It is, and this is T1. It's an iso-intense here, and this is in T2. You can see the bright central scar. For MRI, we use a contrast, either a Primavist or Isovist, depending on which country you are in the world. And this is taken up by the reticular endothelial system in the liver, the Kupffer cells. So, and then it will basically enhance during the imaging. For the MRI, of course, you will need support from a radiologist to help you in making up the diagnosis. You can use hepatic scintigraphy, which is silver colloid. And the reason for this, because as I said, Kupffer cells, in about 10% of cases in FNH, you can have Kupffer cells, and they can, if you do hepatic scintigraphy with technetium silver colloid, they can they can basically be delineated. And it is very specific finding, actually, but unfortunately, it is only about 10% of cases you can have this finding. If you combine all images, you are likely to get a diagnosis in 70 to 90% of the cases. And if the diagnosis remains in doubt, as I said, between FNH and fibrolamellar HCC, then you have no choice. You have to go for a biopsy. FNH malignant elective resection is not indicated in symptomatic patients. And symptomatic unresectable lesions can be treated, again, symptomatic unresectable, can be treated with transarterial embolization or RFA. Many people ask, should we stop OCPs for FNH or not? It is controversial. You can try and see what will happen, but it is not strongly, there's no strong evidence to support that if you stop the OCPs, that the FNH will shrink or will not increase in size. On the other hand, if you have a patient who comes to you with an FNH, they will ask you, can I become pregnant? The answer is yes. There's no contraindication to pregnancy. But you might need to observe these patients with an ultrasound at least once or twice during the pregnancy. For those lesions which are symptomatic, of course, you offer them surgical resection. And these are benign lesions. You can do inoculation and you can do formal resection. I'm going to move now to talk about hepatic adenomas. They are more common in young women, again, as the ratio is 4:1. If you have an adenoma, if a patient has an adenoma of more than 5 centimeters, that mandate resection, it is a pre-malignant. The chance is almost 10% chance, 10 to 15% chance that it become malignant, and that chance is not small. So there is a strong association with all synthetic estrogen and progesterone preparation with adenoma. Rupture may occur during pregnancy due to the rapid growth under the influence of estrogen. Histopathologically, these are basically benign proliferation of the hepatocyte and should not be confused with hepatomas, which refer to the hepatocellular carcinoma. Usually they are solitary. In 70 to 80% of the cases, round, well-circumscribed lesions. They are not encapsulated, but there is a pseudocapsule formed by the compression of normal surrounding tissue. And microscopically made up of monotonous sheets of hepatocyte separated by dilated sinusoid. And very important, there are no bile ducts in adenomas. This is a histological feature distinguishing them from FNH. In terms of presentation, most of the time they are asymptomatic, incidental. Again, vague symptoms, fullness or discomfort. However, abdominal pain without spontaneous rupture abdominal pain with spontaneous rupture can be seen in these cases. So you have to be vigilant, and if you have a patient who comes to you with a liver lesion which has ruptured in the abdomen, I have seen few cases which become unfortunately ruptured, and we have to intervene sometimes surgically or with the IR for embolization. In terms of diagnosis, ultrasound can identify the lesions but cannot differentiate adenoma from other malignant lesions. Triple phase CT scan, hepatic adenomas demonstrate early enhancement, and again, often first to the periphery, and then there is centripetal progression. And as I said, because there is no Kupffer cells in these hepatic adenomas, compared to FNH, contrast enhanced MRI and technetium colloid allows us to distinguish between the hepatic adenoma and FNH. So that is where the technetium sometimes in 10% of cases might help you to pick up patients with FNH if you have doubts compared to adenoma. Unlike FNH, hepatic adenoma frequently appears heterogeneous on CT scan due intratumoral hemorrhage and necrosis. This is a CT scan basically showing the hepatic adenoma. You can see homogeneous enhancement. This is in the arterial face. So this is, and you can see this is basically, there's no you cannot see, of course, not the capsule, but I mean you can see the most important thing is the homogeneous enhancement in this of this lesion. And it is peripherally located, pedunculated lesion. This is how it looks like in MRI. In T2 weight image here, large heterogeneous lesion, strongly hyperintense with contrast. And this is an ultrasound showing basically heterogeneous enhancement in the CT scan here, and also in the ultrasound. This is suggestive of bleeding into the adenoma itself. So how do we manage hepatic adenomas? Okay, because of the risk of spontaneous rupture and malignant transformation, hepatic adenomas must be identified and treated promptly. So please, for hepatic adenomas, it is very important to diagnose them, very important to manage them well, because there is risk of rupture and there is risk of malignant transformation. Lesions less than 5 centimeters, I would say less than 4. Okay, you might give the chance that if the patient is taking OCPs, to stop the OCPs, and some of these lesions might regress in size. Lesions more than 5 centimeters should be resected. RFA can be offered for multiple small adenomas rather than surgery. And of course, even if you offer RFA, you have to keep on monitoring these patients. The indication for intervention, as I said, the lesion more than 5, and lesions if they don't shrink after discontinuing OCPs, and some patients who medically cannot stop OCPs, and patients who have symptoms. These are the indications for operative intervention in adenomas. Some patients might have multiple adenomas, okay? And this is referred to adenomatosis if they are more than 10. And again, they are predominantly in women. Also OCP association, also associated with glycogen storage disease, type 1. In this scan, I'm not sure if it is clear to you, but you can see there is one large lesion in the caudate loop here. There is another one here, and there is another one here. So these are hepatic adenomas. This is in T1 weight image. The risk of malignant transformation in hepatic adenoma is 10%. So resection should be offered for adenomas of more than 5 centimeters, and patients with multiple adenomas, you can target them. If they are small, you can target them with RFA. Some of these patients might end up having liver transplant. I'm going to talk to you about now the hepatocellular carcinoma, which is one of the malignant lesions as a primary cancer in the liver. The annual incidence is about 2.4 in 100,000. Male to female ratio 2 to 3. The incidence in African Americans is twice the white. It is seen in the 5th and 6th decade of life. And 70 to 80% of HCCs arise in cirrhosis. And the blood supply is from the hepatic artery. Major risk factors for HCC: cirrhosis, hepatitis B or hepatitis C, autoimmune hepatitis, primary biliary cirrhosis, and hereditary metabolic disorders. Of course, there are other factors, but these are the major. And also cirrhosis, alcohol related. Clinical presentation: abdominal pain seen in 50% of the patients, weight loss, weakness. Sometimes HCC might present with intra-abdominal bleed. For the diagnosis for these patients, you need a little bit of workup for them, for liver function tests, and you need to do serum alpha-fetoprotein, which can be high in 75% of the cases. It is also elevated in chronic hepatitis and cirrhotic patients, but if it is more than 400 and there is a lesion, you can suspect that's an HCC. Abdomen ultrasound used for screening for patients with chronic liver disease and cirrhotics for HCC. MRI is very useful to differentiate small nodular lesions, which are dysplastic or regenerative from HCC in cirrhotic liver. Triphasic Ct Scan enhances in the arterial phase, and there is a rapid washout in the portovenous phase, sensitivity about 80% and specificity about 95%. Usually, tissue diagnosis is not required in these cases, and we tend to avoid taking biopsies because we don't want to spill the tumors inside the abdominal cavity, and we have good images that can give us the diagnosis. In terms of workup for these patients, you need to be aware of child book score for cirrhosis. Of course, there are three biochemical tests: total bilirubin and albumin and INR, and there are two clinical: the ascites and encephalopathy. And I think you are aware this is medical student stuff, but there is grade A and B and C, and then you look at the points, you look at life expectancy based on the points, and also their perioperative mortality also based on the points. So this is a child book score, and I think you should have an idea about this score because it is important when you evaluate patients with chronic liver disease with the liver lesions. Meld Score in 2002, Organ Procurement and Transplant Network in US began using the Meld Score, which is a model for end-stage liver disease. It incorporates creatinine, bilirubin, and INR in a mathematical equation to derive the probability of 90 days survival. Meld Score less than 9 will experience 1.9% mortality at 90 days. And Meld Score of more than 40 had a mortality rate of 71 at 90 days. So you need also to be aware of the Meld Score because this is also used in assessing patients with chronic liver disease for transplant. Some centers, they use it to prioritize patients for liver transplant based on the Meld Score, of course, in addition to other things. Treatment option for HCC, surgical resection in non-cirrhotic patients. And the predictor for recurrence in this patient is the microvascular invasion and multinodular tumors. Another option for treating this patient in liver transplant. Also, I think you should be aware of Milan Criteria, who was written and described by Mazzafero. It's if you have a single tumor less than or equal 5 centimeter in a patient who has liver cirrhosis, or you have 3 lesions, the largest is less than 3 centimeter. There's no vascular invasion, no nodal metastasis, or no distance metastasis. These patients should be listed for liver transplant. Liver transplant offers the best therapeutic option for survival compared to resection in cirrhotics. Local ablation, best for early lesions, small lesions like less than 2 centimeter. For lesions also not suitable for resection. Local ablation might be used also for to bridge for transplant. Downstage tumors. Local ablation accomplished by chemical injection to the tumor, 100% of ethanol, or by RFA or cryoablation. Necrosis rate for HCC for 2 centimeter lesion or less is about 90 to 100%, but it declined to 50% for large tumors. So for lesions less than 2 centimeter, you can offer them local ablation if you have a good interventional radiologist. For larger lesions, you might use multiple sections, especially if they are inoperable. Transarterial chemotherapy, selective intraarterial administration of chemotherapeutic agent followed by embolization of a major tumor artery. And it should not be used in the compensated child child book score. Local radiation therapy with yttrium-90 uses beta particles emitting radioisotope, selectively injected into the hepatic artery branch and causes destruction through combination of radiation and embolization. This is available in some highly specialized centers as a modality, another additional modality for treatment of HCC. Bile duct hamartomas. I will talk about the bile duct hamartomas after the fibrolamellar HCC. I mentioned to you about the fibrolamellar HCC earlier when I was talking about FNH. First of all, this fibrolamellar HCC is a rare histologic variant of HCC. It is differentiated from HCC by epidemiology, biology of the disease, and prognosis. The prognosis is better than the HCC. It is less aggressive compared to the HCC. In terms of epidemiology, it is common at younger age group. I saw 3 cases in the last 2-3 years, and they are in the age group of 20 to 30 actually. Male to female ratio equal, and fibrolamellar HCC is not associated with an underlying liver disease. Usually the liver is normal. Not like HCC, which 80 to 70%, 70 to 80% develop in chronic liver disease. And it resembles FNH. It can have a single large tumor with dense fibrotic band and form a central scar. This can be seen in 75% of the cases, actually. Treatment for fibrolamellar HCC is complete surgical resection. Liver transplantation is an option for unresectable lesions, but non-metastatic. And they have a better prognosis than HCC, as I said. This is a CT scan of a patient with fibrolamellar HCC. You can see the lesion here. It's a solitary lesion. It is hypoattenuated, well-defined. This is this CT scan with enhanced, of course, this is enhanced CT scan. And it can, after you give the contrast, it enhances homogeneously. You can see the central scar, and you might see also some calcification in 35 to 65% of the cases. And the treatment, of course, for this patient is the best option is surgical resection. Bile duct hamartomas. Sometimes, if you go laparoscopically for a lab chole or for some other conditions, you might see these white lesions, usually peripherally located. They are firm, smooth, and white in appearance. They are the most common lesions seen at laparotomy or laparoscopy. Size variable between 1 to 5 millimeter in diameter, but can be larger. The problem with these lesions, they can sometimes be confused with some miliary metastatic lesions, especially those from colorectal cancer or cholangiocarcinoma. And therefore, sometimes if there is any doubt, they should be biopsied. The treatment options for benign liver lesions, I'm going to summarize the treatment options. I think I've gone through all these topics, and there is a lot of, I'm not sure how much you grasped from what I have said, but I will try to hit on the treatment options for these lesions. So resection is an option for benign lesions. It can be done laparoscopic. It's good for pedunculated lesions or peripheral lesions. We can do also open resection. We can do also anatomic resection by inoculation for the benign lesions. Inoculation is also good for hemangiomas, focal nodular hyperplasia, especially if there is symptoms. Ablation, we can use radiofrequency sometimes to manage some adenomas, small adenomas, or patients who are refusing operation, or they have a high risk for surgery. We can do ablation. You do that with a chemical like alcohol. And embolization, of course, is an option for managing these lesions, especially for poor operative risk patients with symptoms, symptomatic FNH or adenomas or adenomyomatosis. Unresectable large tumors, in an effort to reduce the size, sometimes might help with embolization. Hemangioma or mesenchymal hematomas in patients with congestive heart failure or Kasabach-Merritt syndrome. Embolization might help temporize these patients. Transplantation for adenomatosis that are not amenable for resection or ablation. Patients with glycogen storage disease and who develop multiple adenomas. And for symptomatic GN central located adenomas or hemangiomas with inadequate hepatic reserve. So if you have a patient with large hemangioma, if you are planning to resect and you are going to compromise the size of the liver, then you shouldn't do it, of course. And these patients might be offered liver transplant. These are very scattered, small number of cases has been done worldwide. These are the references I have used for my topic today. And this basically concludes my my talk. And I will be happy to listen for any question from you. And I think there is a set of MCQs. We can ask them at the end of the session. But I'm very happy to listen to you for any question regarding what I have said, if there's anything not clear or something of doubt.
Thank you very much, Doctor, for your lecture.
You are welcome.
We'll do the MCQ first. So if it's okay, if we can go on, and then while giving them a chance to write their questions in the panel.
Great. Okay, shall I go ahead with the MCQs?
Yes, please.
Okay, so you have a 30-year-old female with incidental finding of a 5x6 centimeter liver lesion in segment 6. CA and alpha-fetoprotein and CA99 were normal. CT liver arterial phase shows bright homogeneous enhancement with hypodense central scar, and delayed images show hyperattenuation of a central scar. Which of the following is characteristic of this lesion? So this is the lesion. So which of the following is characteristic of this lesion? Rarely present with an intra-abdominal bleeding, strongly associated with oral contraceptives, has a malignant potential, should always be surgically resected. First, what is the diagnosis? Based on the CT scan and the CT finding, and accordingly, you should be able to answer the question.
I'll give them a few more seconds.
Okay.
So most of them answered B, strongly associated with oral contraceptives.
Okay, so should I say the answer?
Yes, please.
You want me to say the answer and explain?
Well, we would love that.
Okay, so first of all, this is a young female. If you look at the CA and alpha-fetoprotein and CA99 were all normal. These are the tumor markers, of course. So it does not indicate this is a malignant lesion. Of course, you cannot exclude. But when we went for the CT liver, you can see the bright homogeneous enhancement. You can see the central scar. Okay, this is the central scar. And there was a rapid washout. There was a rapid washout here. This is a patient who have a focal nodular hyperplasia. So first you have to make the diagnosis. And if you look at the answers, rarely present with intra-abdominal bleed. So this is actually the correct answer. Strongly associated with oral contraceptives, FNH, no. Hepatic adenomas are strongly associated with oral contraceptives. Has a malignant potential? No. FNH does not become malignant. Should always be surgically resected? The answer is no. You don't always resect these lesions. Especially if they're asymptomatic, small, you can observe and you can follow up these patients. So the correct answer is number 1. Can we move to the next question? Or you have a question? Okay. Sorry. Okay. 60 years old man underwent right hepatectomy for metastatic colorectal cancer. Which of the following describes this condition? Most common malignancy of the liver. Approximately 80% of patients develop metastasis. Chest, abdomen, pelvic CT scan every 3 to 6 months for 5 years. PET CT scan is routinely done. What is your answer?
We have 20 seconds left. Okay, we will stop the voting now.
Okay.
So most of them answered A, most common malignancy.
Okay. That's true. The answer is correct. Actually, this is the colorectal cancer metastasis to the liver are the most common tumors in the liver. The second answer, approximately 80% develop metastasis, is wrong. 50% of these patients, they develop metastasis. Again, please try to recall for those who answered number 3, CT chest and abdomen and pelvis every 3 to 6 months for the first 2 years, but every 6 to 12 months for the 3 years after. This is based on the guidelines. But it is, you don't do it every 3 to 6 months for 5 years. It is done again 3 to 6 months for 2 years, and then 6 to 12 months the 3 years after that. And we follow up these patients for 5 years. PET CT scan is not routinely done for this patient. Any question? Or I move to question number 3?
Yes, we can move to question number 3.
Great. 56 years old man diagnosed to have HCC. CT liver reported 4 liver lesions, 4 centimeter at segment 2, 3 centimeter in segment 4, 4 centimeter at segment 7, and 2 centimeter in segment 8. His child status was child B with Meld score of 12 and serum creatinine of 180. Which factor is the main contraindication for transplant in this patient?
So we have 20 seconds left. Okay, 20 seconds are up, so we're about to close the poll. So, yes.
Okay.
30, most of them, not 3.
The correct answer is, sorry, let me just go for. Okay. The correct answer is the contraindication is for transplant in this patient is the number of lesions. If you remember, I mentioned about Milan Criteria. So I would like you please to remember Milan Criteria by Mazzaffaro because these are frequently used. Of course, I don't want to take you into the details of this. Is a big topic by itself, but this is an overall accepted by most of the transplant centers. The Milan Criteria. There are UCSF criteria in US. There are Barcelona criteria in Barcelona, but the Milan Criteria for a level of resident, you should be aware of them at least as a guide for patients with liver cirrhosis who should be considered for transplant. So Milan Criteria, I'm going to revise it again with you. Milan Criteria, number one, it should be less than, the lesion should be less than 5 centimeters. So if the lesion is more than 5 centimeters, that is outside Milan Criteria. So you have to give some modality of treatment to bring this lesion. If it is, for example, 7 or 8, you might give transarterial chemotherapy and then reassess if it becomes smaller or not, so that you can list the patient for transplant. So that's one. Number two, if you have 3 lesions, all the 3 lesions, okay, each one should be less than 3 centimeters. Okay, so 3 lesions, each lesion should not be more than 3 centimeters. Now, this patient have 4 lesions. So the number of lesions here is a contraindication for transplant. Okay, and the others, of course, you shouldn't have nodal metastasis or distant metastasis or vascular invasion. Regarding the child score, it's child B. It's not a contraindication. As a matter of fact, you transplant these patients who have child B or C. Meld score of 12 is not a contraindication for the transplant, and of course the serum creatinine of 180. Next.
Okay, next.
46-year-old man presented with right upper quadrant pain and fever for a few days. Clinical examination showed hemodynamically normal with tender right upper quadrant and leukocytosis with left shift. Ultrasound abdomen reported 7/8 centimeter liver abscess in segment 4 of the liver. What is the best management approach?
So we have 30 seconds left. Okay, so we're going to end the poll. And most of them answered ultrasound guided aspiration.
Correct. That answer is correct. Okay, now this is a 7/8 centimeter. Patient hemodynamically normal. Okay, so IV antibiotics alone will not treat this condition. Like really very unusual to treat this condition if it is this size. IV antibiotics can work for liver abscesses up to 3-4 centimeter, maybe 5. But beyond that, 7 or 8, IV antibiotics alone is not enough. Laparoscopic drainage, as I said, we usually do not go because laparoscopic drainage requires surgery, requires anesthesia. We don't jump into this option before ultrasound guided aspiration. And the same principle applies for open surgical resection. So ultrasound guided aspiration is the right approach at this stage for this patient.
We can go with
the last question. Please don't disappoint me. Answer this question correct. Which of the following liver lesions had the potential for malignant transformation?
We have 30 seconds left. Five seconds. And we're ending the poll.
Thank you. It's the correct answer is liver adenoma. Please remember, very important, liver hemangiomas, they never become malignant. FNH, no malignant potential. Biliary hematomas, no malignant potential. Only liver adenomas. So the correct answer is the third answer.
Okay, Victor. We have a few questions in the Q&A panel.
Please.
There's one question by Fahad. He's asking, in your experience, have you ever seen a shocked patient after hydatid aspiration or biopsy?
I have not seen a patient with anaphylactic shock, neither after aspiration or surgery. It's actually a very interesting question. If you remember, I have mentioned that we start these patients on albendazole for 2 weeks before any procedure, whether it is pair or laparoscopic intervention or open surgical intervention. So these patients will be given the albendazole for 2 weeks. Also, please remember, when you give albendazole, you need to monitor their liver function test, because if you don't monitor their liver function test, some of these patients, they can have hepatotoxicity from albendazole. And from my side, all the operations, when I go for this operation, I have done for the last 5 years, takriban 3 cases. I always alert the anesthetist that to be ready for anaphylaxis just before I puncture the cyst, because there's a chance that because the cyst is under pressure sometimes and you might spill. But as I said, I put large or multiple gauze impregnated with the hypertonic saline in the subhepatic area. So if anything spills, it will spill there. And when I open, I immediately I'm ready with the suction device. So immediately the suction device go into that hole. So the risk of spillage is minimized. So I have never seen it, alhamdulillah, with any case I have done. But it is reported and documented in the literature. And you have to be ready with the hydrocortisone in these cases, in case there is any spillage or signs of anaphylaxis. Next question.
The next question is how you can tell if a cyst is connected to a duct.
Very good question. First of all, before surgery, the MRCP, the MRI liver with MRCP sequence gives you an idea if there is communication between the cyst and the biliary tree. It can give you an idea. If you can see small channels going directly into communicating with the biliary tree, going into the cyst, that is one. Okay, so preoperatively by MRI liver and MRCP sequence. Next, if you decided to do pair, okay, for the patient, and along with that, of course, we discussed with the radiologist, and he's very keen to do it. When the radiologist passes the needle into the cyst, he should aspirate first. When he aspirates, he should not bring bile. Okay, he should not bring bile. If he brings bile, he should not, if he's going to continue the procedure, he should not use alcohol. He should use hypertonic saline. Okay, he should not use alcohol as a solicidal agent. During surgery, actually the case which I showed you, it was communicating with the biliary system because the cavity was big, and after I removed the germinal layer, which is like a towel impacted inside the cavity after I removed it, and after I fenestrated the cyst wall, there were small metal qanawat. They're coming, and you can see bile coming from them into the layer of the cyst, which I left with the liver. So there was bile coming from some of the channels. So there are two options. One option is to suture this intracorporeal, to suture these channels. The option number two is you leave a drain. You leave a drain, and you do ERCP for the patient after the operation to decompress the biliary system and decompress the pressure in the biliary system. So it helps to reduce the bile leak from this. I personally prefer the first approach because, you know, ERCP is an invasive procedure and not without risks. So for my cases, if I see any bile ducts, small bile ducts leaking into the cyst, inside the cyst wall, through the cyst wall, I suture them immediately. So this way I minimize the risk of bile leak post-op. Next question.
So next question is by Ghassoon. She states that, or he states that, in which cases can we do a liver biopsy?
Okay. Liver lesions overall, you need to exhaust, or you need to use your radiology department to diagnose them for you before considering doing any biopsy. As I mentioned, in hemangioma, hemangioma is a vascular benign tumor. If you biopsy a hemangioma, high risk of bleed, and the bleeding is sometimes difficult to control. You might need to embolize, or you might need to go surgically. So hemangiomas, you should not biopsy. And if you combine the CT scan finding with peripheral nodular enhancement and centripetal flow, and in the delayed portal venous phase, you still have the contrast, this is very likely this is a hemangioma. And if you combine it with an MRI, it will be diagnostic. Okay, extremely rare, really, we miss a diagnosis of a hemangioma. Next is focal nodular hyperplasia. Focal nodular hyperplasia, I have showed you the CT scan. I have mentioned to you about the technetium silver colloid. Also, if you combine the CT scan with the MRI, you are like with the contrast in the MRI, you are very likely to diagnose this patient, to differentiate it from adenoma or a fibrolamellar HCC. If you cannot differentiate FNH from a fibrolamellar HCC, okay, then you might consider doing a biopsy. So FNH, you might do a biopsy, but of course, after you do all the necessary investigations. And the reason why, because if it is a fibrolamellar HCC, you don't want to biopsy that lesion and you spill the tumor. Okay, because once you spill the tumor into the peritoneal cavity through a biopsy, of course, our radiologists now becoming genius, and they sometimes put a sheet and through that sheet they pass the needle, like insulate the needle with a sheet into the lesion, but still there is potential risk for spillage still. So FNH only if you cannot diagnose it after you use all the modalities, the radiological modalities for diagnosis. Fibrolamellar HCC, I will be frank with you, most of the cases I have dealt with has been diagnosed by an MRI and CT scan. So extremely rarely to require a biopsy of a fibrolamellar HCC. The other thing is, in a fibrolamellar HCC, if it is looking like a tumor in the CT scan MRI, big, it requires surgery. If it is requiring surgery, why I go and biopsy that lesion and I cause spillage? On the other hand, I'm going to go for a formal resection. So I avoid taking a biopsy in these cases. HCC, again, with the modalities available, like CT scan, the MRI, it is extremely rare now to biopsy an HCC. So liver biopsy, I am really not an advocate for liver biopsy because I think most of the cases I have dealt with has been diagnosed extremely rare. Maybe 1 or 2% of cases you might get that you might be obliged to do a liver biopsy. But majority of cases, you don't need to do a liver biopsy in them. I hope that answered your question. If yes, next.
Yes, we have one more question left. For how long should we wait until we call a patient for metastastectomy after a primary colonic resection if we decided not to do both procedures in the same setting?
Okay. Good question. If the patient gets primary colonic resection, let us put different scenarios. So if the patient is diagnosed with a colorectal cancer and he has a liver metastasis, and if you remember, I told you if the patient is going for a low anterior resection, or an extended hepatectomy, which means that you are removing more than 4 segments from the liver, better not to combine. Better to do separate, staged procedure, okay? You finish the primary and you do the secondary. Now, if the patient have colon resection done today, the question is, and he has a liver metastasis, okay? Let us say at the same time he had the liver metastasis. If the patient did not have a perioperative complications like leak or wound infections, I would say a major complication, and you can go ahead with, after 4 weeks, you do the liver resection and you give the chemotherapy after the surgical liver resection. The only problem with this, you are going to delay the patient from getting chemotherapy. Okay? So if you look at the biology of the tumor of this patient, lymph nodes positive, aggressive tumor, margins are positive in the colon, maybe you have to be wise and to give the chemotherapy first rather than going for a liver resection. Because if you are going to wait for 4 weeks, sometimes 3 weeks if you can, it depends also on the physiology of the patient, his fit and good patient. And if you do the colon resection, 3-4 weeks you wait, and you do a liver resection, and they had to wait after the operation another 3-4 weeks for the chemotherapy, you are going to wait for about 2 months. You are going to delay the chemotherapy of the patient. So, to answer your question correctly, one is each center, there's an MDT meeting. And that MDT meeting has to follow certain guidelines. Okay? Based on that, you have to manage and tailor your cases. From my side, what is the challenge if I do liver resection in a patient who have a liver metastasis? One, if he got chemotherapy today, the problem is the liver parenchyma get damaged by the chemotherapy. So when we go for resection, 2 problems. One, if we do a major resection, the size of the liver, which we can resect up to 60%. But if you resect 60% in a liver, which is received chemotherapy 3 weeks or 4 weeks ago, it will not be very efficient performance-wise like a normal liver. So the chemotherapy will give us a problem if it is given to a patient and we're going for a major resection. So I usually stop the chemotherapy, make sure that 1 month after the chemotherapy stopped, at least 1 month, if I'm going for a major liver resection, at least 1 month, I make sure that the patient, from the time the chemotherapy stopped, I do the operation. And the other issue is with when you divide the liver, which is damaged by the chemotherapy, there is risk of bleeding, post-op bleeding, and there is risk of bile leak. Because the healing process of that damaged liver from the chemotherapy is not as good as the normal liver. So these are the 2 major problems, which is related to how big is the operation and related to the complications from the resection. So to summarize this, overall, if the patient getting chemotherapy, I stop. I do the surgery after 1 month. I have to wait for 1 month after the chemotherapy so that I minimize the risk of complications. That is why I am an advocate for a combined operation, if it can be done, because you can do the operation 1 go and the patient can get his chemotherapy in 3 to 4 weeks after the operation. So that is the answer for your question. If you feel that they have still any doubt, please, you can rephrase your question and ask me.
So far, no one, other than this is the last question, and no one typed in the Q&A panel. So this is the last of our questions. Thank you very much, Dr. Yahya, for this lecture. It was a really good lecture.
You are welcome, Dr. Lula. And again, I'm just repeating, thank you very much for in giving me this chance to do this lecture. You know, sometimes it's because just a little bit doing this online is a little bit of a challenge, of course. But I hope the objectives of the lectures have been achieved, and I hope they answer, provided at least some glimpse of the conditions that need to be understood by the resident level. Yeah.
They answered most of my questions, so I'm assuming they answered most of everyone's questions. It was a great lecture, honestly, Victor. Just before we go, we have a special announcement for everyone. We are pleased to announce the first plastic surgery course. It's a foundation course. It's the first in the Middle East. It will be an 8-week course, and we would stay tuned because we have a short introductory video of the course. So we will be announcing registration for that course soon. So make sure you follow us on social media so that you can register for the course. And also after the session, register for the next session of ABC research, which is on the 1st of July by Dr. Sarah Lioha. And we have the next surgical fixed sessions on motility disorders, Sunday, the 4th of July by Dr. Alexander Lee. And thank you very much for attending.
Thank you very much. Thank you.
Thank you.